Great, thanks so much, Allison. So we're starting off this morning with a lecture by Roger Bedimo, who is at University of Texas Southwestern Medical Center. He's going to talk about issues around weight gain and HIV. I know it's a question I get from a lot of my patients, so we'll turn it over to Roger.
Thank you so much, Laura. Let me share my slides. Okay, and thank you, and welcome to this session. What I'd like to discuss is antiretroviral therapy and weight gain, also known as does these drugs make me fat? Next. And here are my disclosures. What we'd like to cover today is at the end of the presentation to be able to assess the magnitude of weight gain associated with antiretroviral therapy, identify its predictors, and list potential mechanisms and potential metabolic complications of the weight gain associated with antiretroviral therapy. Here's the first question. We have a 27-year-old African-American woman recently diagnosed with HIV. Her CD4 count is 198, viral load 649,000. She's HBV immune and HCV negative. She's eager to start antiretroviral therapy, but has heard of the potential for weight gain. You tell her that the greatest potential for weight gain is associated with what? Being male and white, starting antiretroviral therapy with integrase inhibitors, with protease inhibitors, with non-nucleoside reverse transcriptase inhibitors, or the jury is still out, or you just want to take a pass. Please vote. Okay, the majority, 62%, correctly identified that the potential for weight gain is greater with integrase inhibitor-based regimens. Let's move on. And this has been discussed a lot, but let's put it in perspective first. HIV epidemic is happening in the midst of an obesity epidemic. Worldwide, about 40% of adults aged 18 or older are overweight. In the US, we best that. 40% or so are obese, not just overweight. And let's also focus on the fact that the most affected demographics are Blacks and Hispanics, which are also the most affected with HIV/AIDS. And also, we will see likely affected by weight gain in HIV. And this has first been described in observational studies. Here's the NAR code. I make 2 points here. Greater weight gains with integrase inhibitors, followed by protease inhibitors, and then non-nucleoside reverse transcriptase inhibitors to the left, and focusing on the fact that the average BMI gain in the first year is about 0.5 for integrase inhibitors, and the weight gain is greater in that first year, slows down thereafter. If you look at the curve to the right, among integrase inhibitors, you see greater weight gain with dolutegravir and then raltegravir and elritergravir. And this is what we just discussed. And let's now move on to the multivariate analysis of weight gain with antiretroviral start. This is a pooled analysis of 8 phase 3 randomized controlled trials of first-line ART initiation between 2003 and 2015. What this study looked at is the identified baseline factors associated with weight gain, lower CD4 count, and higher viral load. Remember this. And also female sex, Black race, symptomatic HIV, and younger age. You'll see here these 3 curves that on the left, integrase inhibitors were associated with greater weight gain. On the right, the newer, in the middle, sorry, the newer integrase inhibitors, bictegravir and dolutegravir, were associated with higher weight gain than the older one, elritergravir cobicistat. And on the right, among NRTIs, TAF was associated with greater weight gain, followed by abacavir, and the lowest weight gain, in fact, weight loss, was people exposed to AZT or CDV. Now, if you look at demographics, again, females gain more weight than males in the left. On the right, Blacks gain more weight than non-Black. And on the right, you see Black females gain more weight. You remember that in the first analysis of NAR cohort, we had about 0.5 BMI gain in the first year of antiretroviral therapy. And now we see that it's mostly affecting Blacks and mostly affecting females. And this is the advanced study, which is very aptly named because actually did advance our knowledge and our understanding of weight gain in antiretroviral therapy. In South Africa, where 99% of the participants were Blacks, we see that weight gain was significant here in males associated with exposure to TAF FTC plus dolutegravir, and then TDF FTC dolutegravir, and much lower weight gain with TDF FTC efavirenz. Women gain even more weight, by twice the rate of males, but the same order of magnitude with TAF FTC plus dolutegravir being associated with more weight gain. And you see at the bottom here that more than 10% weight change was observed in those exposed to dolutegravir FTC TAF. Now, this is a significant weight gain. Follow up in this study, you will see that contrary to data that I just showed you in the US, average BMI increase was 1.5 in males and 2 in females, while it was about 0.5 in the US. So the magnitude of weight gain is a lot higher in this population of almost exclusively people of African descent, as we have observed in the US. And in follow-up analysis to this in AIDS 2020, you see even greater weight gains up to week 144 with females and with dominating weight gain in males. Now, what happens with the newer antiretrovirals? We see that the newest kid on the block for the NNRTI class, which we have seen has been associated with a much lower magnitude of weight gain. The newest one being doravirine, and this pool analysis of phase 2 and 3 clinical trials of doravirine, one comparing doravirine to efavirenz, all of them with FTC TDF, the other one doravirine versus darunavir boosted, and the third one doravirine versus efavirenz. See, the magnitude of weight gain was minimal in either of those arms, and it was not statistically significant. Newest kid on the block in the class of integrase inhibitor is cabotegravir rilpivirine, injectable agents. You see here looking at using cabotegravir rilpivirine every 4 weeks, the pale green, every 8 weeks, the darker green, and then comparator antiretroviral in purple. Median weight gain increased from baseline across all regimens, slightly greater in those exposed to cabotegravir rilpivirine either 4 or 8 weeks. But the proportion of participants with 10 or greater weight increase was similar between cabotegravir and comparator antiretroviral regimens. So thus far, we've seen increased weight gain in people who are previously antiretroviral naive and exposed to antiretroviral therapy. That is greater weight gain with integrase inhibitors and greater weight gain with TAF. Now, you might say at this point that this is just return to health because treated HIV is highly catabolic, and if you control viral replication, you might have the so-called return to health with people gaining weight that was suppressed by untreated HIV. Now, if that was the case, things would be different in those who are already virologically suppressed, which is what we're going to explore next. This is MS, a 35-year-old white male, was been on efavirenz 3TC TDF for the past 10 years. He has been very reluctant to change his regimen that he credited for saving his life. However, he's now willing to consider due to persistent insomnia and depressive disorder. CD4 count is now 700. Virology is suppressed and HCV negative and HPV immune. Now, a switch to dolutegravir plus FTC TAF will likely result bictegravir plus FTC TAF will likely result in A, no change in weight as patient was already virologically suppressed. B, weight loss, since TAF is associated with fewer metabolic complications than TDF, so switching from TDF to TAF will result in weight loss. 3, weight gain because of switch from TDF to TAF, and D, weight gain because of switch from efavirenz to bictegravir or dolutegravir. And C, both C and D. Please vote. Excellent. 78% of the majority correctly identified that the weight gain in this previously virologically suppressed person is greater if they switch from TDF to TAF, is also greater if they switch from a fibrase to an integrase inhibitor, be it bictegravir or dolutegravir. So not just because of return to health in previously naive, even people already virologically suppressed, if they switch to INSTIs or TAF, they do tend to gain weight. This was first seen in observational studies, here the ACTG 5001 and 5322, showing that switch to dolutegravir, elbaptegravir, or attegravir were associated with more weight gain with the switch to dolutegravir. And on the right, a retrospective single-site study, which is more germane to the case I just presented earlier, looked at people on a fibrase TDF FTC, like our patients who switched to INSTIs, either dolutegravir bacavir 3cc or attegravir TDF FTC or elbaptegravir cobicistat TDF FTC. Weight gain was highest in those who switched to dolutegravir abacavir 3TC. And this is NAR code analysis with people switching from an NNRTI to either dolutegravir, oral tegravir, or elbaptegravir, or switching to a PI. Now, switch from an NNRTI to an INSTI was associated with significant weight gain, as you see the curve here, but there was no weight gain. In fact, there was some weight loss with switch from PIs to INSTIs. I want to editorialize here in saying that I'm not presenting to you all the data on switch. For instance, the study NEAT 022 in Europe had looked at switching from PIs to INSTI, and there was some weight gain in that study. But what has been consistently observed is that switching from a non-TDF to a TDF to TAF and switching from INSTI, from NNRTI to INSTI was actually increased weight. And here is the data on weight gain after switching from TDF to TAF. The OPRA cohort switching from TAF was associated with early pronounced weight gain, and weight gain tended to slow down or plateau after about 9 months. Similar data in HOPS, data from 2007 to 218, 736 patients. Greatest weight gain in the first 8 months post-switch associated with INSTI. Some continued weight gain in those who also switch to a TAF in addition to INSTI. So summary thus far in the magnitude of weight gain with antiretroviral therapy initiation in naive patients is that INSTI associated with significant weight gain, a greater magnitude in weight gain in people of African descent and in women, probably greater with dolutegravir and bictegravir than raltegravir, and actually also elbaptegravir cobicistat. Other baseline factors, including low CD4 count and high viral load, that are predicted to weight gain. It's possible that adipocyte dysfunction, we will get to that later, is mediating the INSTI associated weight gain, while the mechanism for TAF is still incompletely understood. NRTI also greater weight gain with TAF. NNRTI less conducive to weight gain, in fact, maybe conducive to weight loss. But it's important to balance the benefits of these newer antiretrovirals, INSTI and TAF, with the risk of weight gain. I want to reiterate that in the antiretroviral regimens recommended for most people by DHHS, INSTIs are still recommended for most patients. Now, if you look at the data for people who do not have HIV, so we show that those with HIV gain weight if they switch or start INSTIs or TAF. Now, what about those who do not have HIV? Let's first look at IPREX data. FTC TDF versus placebo, there's delayed weight gain in those who are on TDF. So TDF might actually be suppressing weight gain. While HPTN 083 and 084, by the way, show overall significantly increased, greater median weight increase from baseline with cabotegravir compared to FTC TDF. So, and right hot off the press, but a couple of days ago at ID Week, we're now seeing that if you look at analysis of people who do not have HIV, i.e. PrEP studies, from IPREX that are presented earlier to TDF2 to voice PrEP and others, you will see that initiating PrEP with TDF was associated with weight loss versus initiating placebo in this placebo control study. Secondly, as I showed you earlier, HPTN 083 and 084 showed that initiating TDF-FTC delayed weight gain compared to initiating cabotegravir. So it's very possible that TDF and also efavirenz and nevirapine are associated with suppressing weight gain, which is different from what we're seeing with weight increase with DAF and INSTIs. Let's now finish with the third case. Now, gaining weight is possibly a cosmetic problem, but does it incur a metabolic risk in people living with HIV? WG is a 30-year-old female who has been on TDF, TAF, FTC for the past 2 years. Viral loads is suppressed, CD4 count is 640. Since initiation, she has gained 30 pounds from 210 to 240. Her fasting blood glucose has increased from 99 to 135. She reports no change in diet or exercise level. Studies have so far shown the following cardiometabolic risk of her weight gain. There is no risk of metabolic complications since most weight gain is lean, not fat. There is a decreased risk of insulin resistance due to suppressing viremia. There is an increased risk of metabolic syndrome, and there's an increased risk of cardiovascular disease. Please vote. All right, so I think I have nothing to tell this audience. 83% correctly identified increased risk of metabolic syndrome as the possible complication of the weight gain associated with antiretroviral therapy initiation. Now, studies have not conclusively shown an increased risk of cardiovascular disease, and this has gone for the advance in South Africa and also cohort analysis of DAD study in Europe. Let's look at the data. First, the potential mechanism. It's possible that dolutegravir or ratutrelvir increase the production of adipocyte stem cells in adipocyte, and that do induce adipocyte dysfunction and possibly insulin resistance. So we have an inkling of the mechanism of not only weight gain with INSTIs, but possible metabolic complication. And the yin and the yang of weight gain is adiponectin and leptin. And decreasing leptin is usually associated with weight increase, while increasing leptin is also associated with weight increase. So in the NEAT 022 that I referred to earlier in Europe, switching from a PI to INSTI was associated with decreased LDL cholesterol and CRP and soluble CD14, all good things, but also decreased adiponectin, which is associated with the increased weight gain. So now we have a balance between all these very positive metabolic implications of INSTI versus the negative one of weight gain, possibly mediated by decreased adiponectin. And in advance, we see that most of the weight gain in dolutegravir arms was fat gain in both trunks and limbs. So it's not just lean fat that increased in advance. So it's a fat gain and in the trunk. And now central obesity is what has been mostly associated with metabolic complications in the general population. And if you look at the DAD studies, gaining at least 2 kilos has been associated with the increased risk of diabetes, but not a significant increase in cardiovascular events. Back to advance, we've seen the weight gain at week 96 and week 144, which was greater with females than in males. But I want to focus on the fact that there was treatment emergent metabolic syndrome at week 96 that was greater for those exposed to dolutegravir plus FTC TAF, especially women. And then finally, a reprieve, which we eagerly awaiting to tell us whether, even if you don't qualify for statin initiation with HIV, statin might still decrease your metabolic complications and mortality, has already showed us that there is increased waist circumference with initiation of integrase inhibitors, as well as possible increase in metabolic syndrome. While for TAF, we are seeing that switching from TDF to TAF, as we've seen in many studies before, and this is the Swiss cohort, is associated with increased lipids. So INSTIs will decrease your lipids, we switch from a PI. TAF will increase your lipids, we switch for TDF. Both of them will increase your weight. So it's possible that the mechanism of weight increase is different from these two classes of drugs. Now, what can you do in your patients who experience increased weight, or indeed better, before you initiate them on antiretroviral therapy? It's important to advise them of the real potential for increased weight, especially if they are on the demographics that are more likely to increase weight. There is no good evidence thus far that switching to non-INSTI, non-TAF, for people who are gain weight on either of those classes of drugs will be associated with lower weight. There are case reports. We are eagerly awaiting ACTG 5391, which will tell us whether switching to non-INSTI, non-TAF will lower the weight and improve metabolic outcomes. Unfortunately, this is enrolling really slowly, but we hope that that will occur. Moderate intensity aerobic exercise plus nutritional optimization, highly recommended. Studies have shown that you cannot lose a lot of weight with exercise. It's important to decrease caloric intake. And these are the ADA recommendation, 1,200 to 1,500 calories a day for women and 1,500 to 1,800 for men. And energy deficits has to be demonstrated. An evidence-based diet that restricts certain types of food to create energy deficit. And again, hot off the press, at the week, there was improved, that improved diet was associated with lower ART-related weight gain. So this is a very important message. You can tell people that if you change your diet while you start antiretroviral therapy, the odds of gaining at least 5 kilos were decreased by 30%. This is incredibly important message to tell your patients. So let's summarize now. Accumulating data is that INSTI and TAF-based regimens are associated with a greater weight gain than other regimens, and also PIs to some extent. Increases in weight on dolutegravir are higher in women and Blacks and Hispanics as well. Initial data on patterns and mechanism of weight gain shows that it's mostly fat with INSTIs. We need to evaluate the effect of appetite, caloric intake, and energy expenditure. And the studies I just talked to you about from IDWeek are a step in the right direction. We need to look at what happens to mitigate this weight gain. In metabolic complications, there is a possible increase in metabolic syndrome and insulin resistance with weight gain in antiretroviral therapy. In patients with significant weight gain, we do not yet know if changing to non-INSTI and non-TAF regimens will help, but we do know now that diet and lifestyle modifications do actually help. So I thank you for your attention, and I'll have some time for questions.
Great, that was an incredibly clear and thorough summary of the issue, so thank you so much. A couple of the questions came in as you were speaking, so you addressed them, but if you could just give a brief recap. So one of the questions is there a difference between people that are newly starting antiretrovirals and those that are switching in terms of weight gain, like total amount of weight gain?
Yes, actually, thanks for the question. The magnitude seemed to be relatively the same, but it's difficult to compare between studies because people who are virologically suppressed are usually different than people who are initiating antiretroviral therapy. What I try to do with the NAR code and other studies that I have reviewed is to try to boil it down into average BMI increase. And it looks relatively consistent that you will gain about 0.5 in your BMI in your first year of antiretroviral therapy when you start. And the switch studies have a relatively same magnitude of weight gain in people who will switch to INSTI and some of them on TAF, maybe smaller.
So also a question I think you answered, but if you could just summarize again around associated weight gain with PrEP for people using TAF compared to compared to
TDF, yes.
TDF.
So the first group of studies we have studies comparing TDF-FTC PrEP with with placebo, from IPREX to TDF2 to voice PrEP and others. We see a delay in weight gain with starting TDF, which suggests that TDF actually may lower your weight compared to the placebo. Then we look at studies like Discover, where there was a kilogram difference in weight between those who were on TAF versus those who were on TDF. So there's an increase in weight when you do start PrEP with TAF FTC versus TDF FTC. Finally, we have studies comparing HPTN 083 and 084, comparing TDF FTC to cabotegravir and showing that there is slight increase in weight with the Integris PrEP compared to TDF. So the summary of this data suggests that it is very possible that TDF, just like it's been shown, lowers your lipids, may also lower your weight when you start.
So do you avoid TAF in patients that are actually worried about weight gain? Like that's something they talk about when you're first starting antiretrovirals for them, or talking about a switch?
Yeah, so that has been a very difficult question for me, because I do not want to jeopardize simplicity of the regimen as well as other tolerabilities. Because we now, if I do have a person who is already has a BMI of 30 or more, is Black or Hispanic and a female, and who start with a CD4 count that is very low, I know that this person is likely to gain a lot of weight. Now, not everybody gain weight. There's a lot of variability, but it's important to counsel that particular patient that there is a significant risk of weight gain. I wouldn't want to start that person on the PI-based regimen necessarily, because I know a real risk of cardiovascular complications in that person. And maybe the newer integrase inhibitors that are not associated with weight gain would be a better thing for them, but I would not say that I want to do that because the data is still not clear. So I want to make sure that I can consider that. This is where I believe we're heading towards individualizing the care of the person in front of us. And also now I need to tell them that that exercise will help. Sorry.
What about elbapentagravir? What do we know about elbapentagravir in particular?
Yeah, so elbapentagravir, unfortunately, always used with cobicistas. So that is one of the main confounders. So the Gilead pool analysis of the Gilead data by Sachs et al. A couple of years ago looked at elbapentagravir compared to dolutegravir and raltegravir. There was no data comparing that to raltegravir in that particular analysis because it didn't contain that. And that and it suggests that elbapentagravir cobicistat was actually a smaller amount of weight gain than either dolutegravir or bictegravir. And we've seen similar associations with raltegravir being associated with less weight gain than dolutegravir and bictegravir. So I think we can summarize that these two first generation integrase inhibitors were associated with less weight gain than the newer ones.
Oh, great. There was another question about age related. So if you have a newly diagnosed patient who's 20 versus 56, is there a difference in weight gain if they go on a combination that's likely to cause weight gain?
Yes, so I mean, that's been one of the predictors, low CD4 count and high viral load being one of them, and younger people tended to gain more weight. So I don't know that I would necessarily consider that in starting antiretroviral therapy. The older patients, what we do have now is that, again, we need to put everything in context. We first have to look at the very real metabolic complication of the older person, from bone loss with renal dysfunction to the real polypharmacy. So the fewer drugs and the more drug interactions we have in this older patient, the better. Weight gain may have to be factored in as well.
Okay, and do you, what do you think about dolutegravir or lamivudine as sort of a happy medium, kind of split the baby in the middle?
Yeah, so it would have been nice if the OPERA and other cohorts had showed us a significant improvement in weight with switch and as well as so we do have data on Gemini now with studying dolutegravir lamivudine, and we do have Tango and Salsa switch to dolutegravir lamivudine. There's not been a significant change in weight with that switch. And that is something that we're gonna continue to try to get more data from.
Okay, and what about fatty liver? Does this come into play as people start gaining weight related to these drugs?
Yeah, it's an excellent question because we know the associations between visceral adiposity and liver fat. And so what I'm personally interested in seeing now that since we have inklings from Advance and others that a lot of us, or most of the weight is fat gain, and that fat gain was observed in most both trunk and limbs. We do not know if it's visceral adiposity. Again, it depends on the measurements people use to look at weight. If you look at DEXA, it will tell you that this weight that you're measuring is in the trunk. It won't tell you if it's visceral or subcutaneous, which we need MRI or CTs, and those type of studies are not yet available to tell us. And we can look at other things like hepatic steatosis index to infer whether we again we getting an increase in liver fat, but the data on that is not as clear as I would like, as far as I know.
And so, in terms of managing weight and diet with your patients, a lot of our patients are in situations where we don't have good access to dietitians. Is there anything that's being done in clinics to really help support weight loss for people with HIV?
Yeah, there are some examples in different clinics, not a lot of randomized data that I can point to. We now having a lot of people cognizant of the fact that our aging HIV population, now we have more than 50% of them over 50 worldwide. In the US, it's a lot more. Now we have to manage frailty. And so exercise and to mitigate frailty has been looked at and has been beneficial. And one of the ancillary benefits of such interventions have been weight management. So I think that if we extrapolate from this data, we will say that we probably should not begin to emphasize in our health maintenance interventions in our people living with HIV, exercise, not only to stave off frailty, but also to mitigate weight gain.
So what do we know about weight gain in pregnancy in these drugs?
So that is very interesting. Now the data, the time didn't allow me to get into that. We have had studies mostly in Africa. And this is actually one of the earlier data that suggested to us that efavirenz may be associated with weight loss, because we had women who were on integrase inhibitor with pregnancy did not gain more weight than the non-HIV population. But women who started efavirenz gain less weight than the general population. So if you are having a pregnant woman who's gaining less weight, it's possible that is not a good thing, but we don't know that for a fact. So it's important to to consider that. Now, of course, this all has been upended in the past 3 years with the data with concern for neurotube dysphagia with dolutegravir. Thankfully, the newer analysis have dampened that concern. and so it's important to know that those who took dolutegravir in pregnancy in earlier studies were not gaining more weight than the non-HIV people with similar gestational age. And so we don't, I don't believe it's gonna be a big problem, but we probably should get more data on that.
So there's a couple of questions about why a lot of the first-line regimens continue to contain TAF and INSTIs giving all this weight gain. Is there any movement to have guidelines change, to have TDF become more preferred?
Can I take a pass? Okay. Well, so for full disclosure, I'm a member of one of the guidelines panel, the DHHS, and I'm not speaking for the DHHS guideline panel. And the reason, but I can say that the reasons the integrase inhibitors are still preferred for most, and that is because of the balance of all the metabolic, not only of the virologic efficacy, the rapid drop in viral load, as well as the robustness and the high genetic barrier. For several reasons, these are important regimens to start. And also, we know now about weight gain, but we also have to consider that lipid changes are a lot better. NEAT 022 have showed us that, and other studies since then. And so it's important to not throw the baby out with the bathwater. It's the weight gain occur in a substantial proportion of people. It's possible to mitigate it, but in the balance, we still think that this is INSTIs are preferred for most. Now let's go on to TDF. The data now is we've seen TDF compared to TAF be associated with lower lipids, and now we've seen that it's associated with a lesser weight gain, in fact, some weight loss. The reasons many bodies have shown, and the DHHS has not completely removed TDF from preferred agents, is that there was concern for two toxicity issues, bone and kidneys. Newer analysis now are suggesting that the effect of TDF on the bone, and actually also on the kidney, is almost entirely limited to their use in conjunction with boosted agents, boosted protein inhibitors. So using TDF with efavirenz, which is mostly used, or other than RTI, may not have the same bone tolerability issues as others. So it may be time to think or rethink the place of TDF in our armamentarium based on everything we know thus far. But this is my own opinion. Okay.
Got it. Okay. Yes, there are a lot of there can be a lot of questions about switch. We'll get to that second, but first, two populations in particular. Do you see the same weight gain in children and adolescents with integrase inhibitors as you're describing here for an adult?
Yes. So the PrEP population, let's say the younger adult more than genders, and are not as familiar, excuse me, I must apologize, with the data on children, but the younger adults suggest that the weight gain with TAF-FTC, thanks to the Discover and others, is also significant for that young adult age group 18 or above. It's possibly the same for children, but I must confess that I do not I know the data.
And do we know anything about transgender females on hormone therapy with regard to the weight gain with women?
Yes, incredibly important data, not only considering the magnitude, but also considering the possible metabolic complications on those. Data is sparse. What we're trying to do here in Dallas is that looking at the largest HIV cohort, they have a small number of transgender. We've seen that weight gain in this small group is also substantial, probably greater, but we're trying to analyze adipokines and others to see what happens, and is it related, is it magnified by the use of hormones? It's important questions to address. And also say that I had hoped that by now we had made a lot more strides on mechanisms than we have. I think it's an incredibly important clinical question that we need to continue to study.
Speaking of mechanisms, what is a mechanism for TAF in terms of weight gain?
I do wish I knew. So the hand-waving explanation here is that the important the difference between TDF and TAF is intracellular versus serologic levels of the tenofovir active moiety that achieve. So TAF has been, purported that the greater tolerability in bone and kidneys has been because most of it getting into the cell and less of it in the in the serum. But that may be the reason why there's also a greater weight gain. But I would be lying if I knew that for a fact. If I said I knew that for a fact.
Okay, and we've probably had 15 questions about switching. Would you recommend switching around for reasons of weight gain or for reasons of increased lipids?
I do know the data for switch for lipid management, especially TAF2F TDF. However, I do not know the data switching off of integrase or off of TDF off of TAF to TDF. There have been case reports that this has been associated with improvement of the weight gain. And as I said earlier, I really can't wait until we have data from the ACTG 5391, which addresses exactly that question.
Great, and with that, we are out of time. Thank you all for a lot of great questions. We got to many of them, and I'll turn it back to Allison. Thank you, Dr. Bedimo.
Thank you.